Welcome to Gaylord's Vent Weaning and Home Ventilator Education Series. I'm Lorraine Cullen, Director of Respiratory and Radiology Services at Gaylord Specialty Healthcare. Weaning from a ventilator is a delicate and unpredictable process. There may be many stops and starts for your family member along the way. And if your loved one is unable to wean from a ventilator, there will be some difficult decisions to make regarding their long-term care. In this video, we will broadly discuss the vent weaning process, as well as Gaylord's vent weaning program and destination vent program.
If patients in an acute care hospital have difficulty breathing, they may require the placement of a tube into their lungs so that a ventilator takes over some of the breathing functions for a period of time.
When a ventilator patient is admitted to Gaylord, they will be admitted into one of two program tracks: the Vent Weaning Program or the Home Ventilator Training Program. Patients in the Vent Weaning Program are accepted with the goal and expectation that they will wean from vent support. Patients who will not be able to wean may be accepted to Gaylord's Destination Vent Home Ventilator Training Program. In this second track, the patient's caregivers, most often the family members, will be trained to provide ventilator care for the patient at home. Before a patient is accepted to Gaylord, our pulmonology department will review their status. If we determine your loved one is on the home ventilator track or is likely to be, then someone from Gaylord's respiratory therapy team will meet or teleconference with the family to discuss requirements of going home on a vent before the patient is accepted to Gaylord. You'll also need to get pre-approval from the patient's insurance company. Sometimes there are hurdles and challenges with the insurance approval, so it is important to work on this ahead of time with the help of our care management team. Our care management team starts planning your discharge from the day of admission to ensure you have a safe plan in place that meets your needs. They will work with insurance companies and provide them updates regarding your loved one's progress.
When somebody is admitted for ventilator weaning, the discharge plan starts on admission. We need to get authorization prior to a patient coming here. And then once the patient is admitted here, we need to get authorization. We send reviews weekly and get authorizations on a weekly basis. To get continued stay for a long period of time could be challenging because we're a hospital level of care. So we always have to strive to have a safe discharge plan in place for a patient.
Once a patient is admitted, we use an individualized approach to tailor the weaning process to each patient's needs. We also use a team approach to coordinate each patient's care between disciplines.
Our weaning here is a process done on a daily basis that is multidisciplinary, involving our nurses, our respiratory therapists, physical therapists, occupational therapists, and the pulmonary staff. We have certain protocols that if a patient is able to wean based on the protocol, they are able to come off the ventilator in approximately 7 days. What we do during those 7 days is we try to look at all the other conditions that have brought the patient to the hospital. Do they have heart failure? Do they have a neuromuscular problem? Are they in renal failure? Once we establish the underlying diagnoses and a therapeutic plan, then we move forward. Our goal at Gaylord is to accept people who have a potential to wean in approximately 30 days. That means that in the first 2 to 3 weeks, we are trying a varying number of tricks, techniques, and medication to improve the general function. And that's where our OT, PT, speech therapy departments come into play. We have a weekly ventilator conference to discuss ventilator progress for our patients, and we make some joint decisions on the future of rehabilitation.
Patients usually start with an endotracheal tube, and after a few weeks, if unable to wean, will transition to a tracheostomy tube, which is a more permanent airway. Having a tracheostomy does not dramatically change the weaning picture, but it may be easier for the patient to bypass the upper airway than to breathe through a thin endotracheal tube that feels like a straw.
The tracheotomy simply moves the tube from your upper throat into your neck. It does not change your lung breathing capacity. It does not alter any of the underlying biologic or physiologic problems. It makes it easier to move a certain volume of air without the risk of complications to the vocal cords and upper throat, but the underlying problems are unchanged.
There are some specific challenges for patients weaning from a ventilator. If the patient had a long acute care course, they may not be used to breathing unassisted. Patients may become anxious breathing on their own, feel dependent on the vent, or fear not being able to breathe. At Gaylord, we try to maximize the amount of time a patient can be off the ventilator while still ensuring that they always feel safe and supported.
Patients are always afraid that they are going to feel like a fish out of water, which is a very realistic and real fear. Our first goal is to make sure that the patient is aware that no matter what they do, no matter what their decision is, they will always have appropriate support from Gaylord and the Gaylord staff.
The psychology staff are experts at assessing anxiety and agitation throughout the process. And we want to look at that along three factors. A person can show physiological signs such as changes in their heart rate and blood pressure, psychological signs such as anxiety and anger and fear, and behavioral signs such as agitation. And so the psychology staff will be continually monitoring the patient. There are a number of things we can do to help relieve a person's anxiety that can range from progressive muscle relaxation, guided imagery, using some of their favorite music, distraction techniques, and classical conditioning approaches that have been found to be very successful at decoupling the vent machine itself, the process of weaning, and the anxiety that has become associated with that process for many people.
The weaning process can be stressful and anxiety-producing for the patient and family. It's okay to start and stop the process depending on your loved one's health situation and progress in weaning. Gaylord's psychology department will meet with the family and the patient to provide support throughout the process. Generally, if a patient is not making strides with weaning after the first few weeks, then we'll have to start discussing home ventilator care or other long-term options. The determination that a patient isn't progressing is made as a team by the patient and their family in close consultation with the patient's doctors and care team.
The process of deciding you cannot wean comes from closely involved family and patient process during the entire weaning process. And it comes from the input from the respiratory therapy staff, from the physician staff, the nursing staff. It is very important that everybody be comfortable with a decision that we cannot wean you. That's why it takes us 2 to 3 weeks here before we even begin to raise that question.
The inability to wean is a difficult crossroads, and patients often feel discouraged. Patients and their families will need to be prepared for some challenging conversations and decisions. If a patient is unable to wean, the only options are to bring them home or to seek out long-term care facilities, which are extremely limited in Connecticut. Often families consist of working adults with many other responsibilities, and it is not feasible to be available 24/7 to take a family member home on a vent. There is also a huge impact on family life. Vent patients cannot be left alone, not even while the caregiver runs to the store or takes a shower. Someone must be within earshot at all times to hear the alarms and address the patient's needs. If you decide to take a family member home, you will need to equip your home to support the ventilator, and the family will be responsible for the ventilator care.
Home involves a lot. It's a 24-hour, around-the-clock, 7 days a week job to care for a patient on a ventilator. We have a whole protocol in place to train patients and families on management of a ventilator. We could help plan all that. We would put in safe discharge, we would get home care. That does not include 24-hour home care. The family is primarily responsible for the care of the patient, but we would help facilitate all the oxygen companies and all the needs that you have, and we would work with the family side by side for the best plan for that patient.
Nursing staff will only provide nursing care. They will not handle the ventilator at all due to liability. There are extremely limited options for hiring private caregivers, and many are limited by their license in terms of handling the ventilator. The family and/or caregiver is completely responsible for 24 hours a day, 7 days a week, hands-on ventilator care and management. After a patient is discharged home, you will need to call 911 in the event of an emergency. Gaylord cannot provide care once the patient is discharged home. For equipment-related issues, you will be provided contact information from the home care company. If a patient is unable to wean and they cannot go home, then the only alternative is a long-term care facility that accepts ventilator patients. There is only one facility in Connecticut that will take someone on a ventilator, and there are extremely limited out-of-state options in the surrounding area. If a patient decides that they do not want to live long-term on a ventilator, Gaylord can help the patient and the family explore options for comfort care or hospice.
When we cannot succeed, we have to accept the fact that there is a higher power that is directing us in a direction that we have no control over. Families who have emotional support, families that have religious and spiritual support, should look to that as an additional guide and support to help reach the decisions that are extremely difficult in a time of crisis. Most of the time, the crisis is slow building in this institution and rarely comes overnight.
Some people choose that they would prefer not to be discharged home to the community, in which case palliative care and comfort care options are a consideration. And we have relationships with programs in the community to consider the role of hospice and comfort care. That's a very difficult decision for families and their loved ones, and the psychology department is here to help you every step of the way.
It's important to keep in mind that psychology resources are not just for people with mental health issues or those who are depressed. Gaylord's psychology department is here to help and offer support to everyone throughout the entire process. For more information about home ventilator care, please refer to the other videos in our series. We hope this video will help you to make the very best decision for your loved one and your family.